Recording now.
Okay, can I go ahead and go get my coffee real quick?
Yeah, I'm still starting the recording.
Okay, it's fine. Okay, that's fine.
Let me see if I can get this. Yeah. So we should be. Are other people going to hit this on? They probably will. They can just send out the information though, because the other call wasn't working. Just telling them. This is very helpful. Perfect. Okay, this is the recording that we're meeting with the social worker and with Valor to talk about Mom and her care plan. So if anyone wants to dial in, I'm recording this so that folks can listen to it later if they need to.
I'm Kirsten Miller, hospice social worker.
My name is Peter Miller. I'm the chaplain with Valor Hospice.
I'm Sherry Warner, and I'm the case manager for Valor. And I'm Sherry McWhorter. I'm the LPN for Lexington Nursing Home.
And we're waiting for Ann to get back with her coffee. We have someone else on. Jamie, can you hear us?
Yes, ma'am. Jamie's here.
Sherry is also the RN for Valor, as well as the case manager.
Jamie is the oldest granddaughter.
Okay.
She is my oldest brother's daughter. She's older than me.
Oh. You said that with a smile.
You can't tell I'm older than her, though.
It gets better and better.
Brat. The other call wasn't working, James, so we used this one instead. Hi, Dottie. Come on in, Dottie.
You guys good enough to speak good or not?
Okay. Grab a piece of pizza.
Did we'll get on there?
Not yet. Jamie's on. Okay, you're being recorded, by the way. We're being recorded, James.
Okay.
Okay, so Anna's back. Anna's here as well. Anna's been the primary caregiver for Mom for the longest time. She does almost everything. So we all try to pitch in where we can.
So I think Ann had a good idea about calling a plan of care meeting to kind of discuss your mom's current situation, medical status, and how hospice works with her, the family, and the nursing home, and kind of the signs and symptoms we're seeing and what those mean, and any questions you all have about hospice and how we're working with your mom. Or grandmother.
Hey, Sheila, I just sent some new information on the call. The other call wasn't working. Okay, so if you want to look at the Facebook family message, it's on there. Yeah, so look at that message and dial into that. Jamie's on. Okay, yeah, go ahead.
Okay, well, there's something that I was, got something brought to my attention, I think this week, early this week, I think this week is coming together, but the biggest thing to know and for everybody to think about is y'all's mom and grandma is having good days and bad days at this point, and the nursing home has talked a lot about, since she had been sick the last time and at the hospital, that her fatigue has been much more, and I would agree with that. And in that, there have been times when she was so lethargic that she hasn't been safe to be able to eat. And yet, in spite of getting up and on days like that, that there will be times that if we feed her when she's too sleepy to eat, that she will be at risk for aspiration. She's already at risk for aspiration anyway because of her status and difficulty swallowing, and needing a special diet. But there's going to be times where if we feed her when she's not awake enough to swallow, there's a very good chance that the food is actually going to get down in her lungs instead of down her esophagus to get to eat. So with
So that's
our
what aspiration is when something gets into your lung instead of where it's supposed to
and
be.
that causes pneumonia,
Okay.
which very much so could cause her demise.
Okay.
So in situations when she's gotten up to eat and she's not able to wake up enough to be able to swallow, feeding her is a bigger risk than her not eating at that time. Now, that doesn't mean if she doesn't get fed one time, that when that evening happens and she's hungry and she wakes up, that she is ever going to be withheld food, because she will be offered the food at every meal time. If she wakes up later, I'm sure that snacks or supplements can be offered as well. But if there's times that she is like that, her safety would be at risk for feeding her when she can't wake up for that.
Hi, Sheila.
Hi. Yeah, I can hear.
We hear your
I'm listening. Do what?
we hear your chickens.
Oh, I'm sorry. I'm letting them out.
So we have Louise on for Alzheimer's, and we admitted her on February 24th after she was in the hospital for 2 weeks with all of her medical issues. We do have her as a do not resuscitate. That means if her heart stops by itself, there would not be CPR done or any jumpstart her heart or any kind of medicine, and we would allow her to go on as God intended. We do have Ann as her medical health care proxy durable.
Hey, Sheila, can you mute your phone?
Yes.
And I have a question. Like, Sophia's been staying a couple of nights and been noticing she coughed last night too. Yeah, she's been coughing a lot. Would she get antibiotics if she got like pneumonia or something?
Yeah.
She would still get that?
If she were to get pneumonia, we would call Dr. Guy and we would get her treated. If he wanted to chest x-ray, we would do so. If not, he might just order antibiotics under the assumption that it sounds like that's what's happening. Now, this is where things start adjusting. If we did antibiotics and the first antibiotic didn't work, and then we switched to a higher power antibiotic, and the second antibiotic didn't work, that's where we start having to wonder, where are we doing aggressive treatment versus where are we doing supportive therapy. So an antibiotic, if not working, trying a second is definitely within the realm of treatment. But also knowing that she is having more dysphagia, which is the difficulty swallowing, there's times when we treat somebody with an antibiotic, that doesn't work. We try the second antibiotic, it makes them feel better for a little bit, but then they continue to have aspiration risk and issues and might continue, even though they're on special diets and on thickened liquids. But she's not on thickened liquids yet.
She's not.
But that could be something we could adjust. If those things do not fix the problem, there are times when you can't keep people on antibiotics eternally.
Right.
That at that point that we would discuss what are the options and what can we do. If she's so weak that she is aspirating on everything that she takes, and we've done the other things and she didn't get stronger, that what are we doing here and are we helping her at this point? So that's more of something that we don't even know that is coming yet. I just know that we will create aspiration pneumonia if we feed her when she is not arousable enough to eat.
Right.
And in the situation of the other day, we didn't feed her because she was too sleepy. She took medicines and pudding, and then she had a little bit to drink, and then within 10 minutes, she coughed about 8 times. And that is, even though if a person is likely to aspirate, sometimes they won't respond right away, but often in 5 minutes, if I'm sitting with a patient who's struggling with swallowing, they'll start or they'll cough. Then I still have to know that there's a risk that they're ones that are going to be, they're getting it down the wrong pipe, and they might be working it out, but it's starting to happen. Does that make sense?
Yeah, that does.
And the few times that you've watched her swallow, right now she's been good at swallowing, except when she's not awake enough.
Except for when she's not awake.
Right.
Yeah. And the thing about thickened liquids is, I mean, we could put her on thickened liquids tomorrow, but if we do, is she going to drink as much? And
right.
I know that some people do not like it. It's not supposed to taste funny, but a lot of people, when it comes to the difference, texture is important. And when you drink your water and you have it be more like honey, it depends on your preference. And some people will quit drinking altogether, which is going to make her at risk for dehydration.
Right.
So it's kind of one of those things you got to weigh the positives and negatives on for that even.
Okay. We've been feeding her like some of the foods here, but also some of the baby food.
Mm-hmm.
That seems to work really well.
And that's equivalent of puree, which is good,
yeah.
and that's totally fine. You know, if she eats and she's hungry, encouraging her to eat is good.
Right.
If she's sleepy and doesn't want it, we have to listen to what she's telling us with her body.
Right. And yesterday she was peeing a lot. She was urinating a lot. We came back from my house and she was soaked, but then the CNA was upset. She thought they had left her a long time, but then she went back in like an hour later to get her up.
An hour later?
Less than an hour later, and she was soaked again. So she was just, urinating a lot.
I've been feeding her a lot of
You've been
water.
but you're
And if she drinks more fluid, she will have more output, which is
Well, I
good,
didn't
because that
know.
flushes your kidneys. That's
Yeah.
positive.
If that was a sign or anything, or she just.
I think it's probably time that she drank more.
She's been there more.
Yeah.
And the more she drinks, of course, the more that she will pee. And pushing fluids, if she's able to swallow them and not cough a whole lot and choke, is good, because it's going to keep her from most likely helping to keep her kidneys flushed, so she won't take an infection. So that's good. Now, there were some things happening last week that showed very promise of big decline, and I talked about that with y'all. It stopped, but in my past history, when I've seen people do that and do better, it still seems like it comes up again at sometimes, like more like a roller coaster ride.
Yeah.
She's doing worse, she's doing better, she's doing worse, she's doing better. And that. So we just need to watch and know that she is declining in her status. I mean, she is. Even
right.
Everybody that's worked here told me that the difference in her before she was sick and went to the hospital till now is different.
Yeah.
Yeah. So some of the things like what you were seeing, you saw her have.
Hey, Roll. Who's on the phone? If you're not muted, can you mute your phone?
Yeah.
It's a lot of feedback. Thank you. And then we have Randy on as well.
So what you were seeing earlier this week or last week was apnea, which is serious of the breathing is not occurring. And so that kind of gave you one of the first inklings, like this more of a decline than we had seen. And we stayed a couple hours with her to watch that and have the on-call nurse come out and check.
Mm-hmm. And she was better in the evening. But typically that happens as a person's declining and they're even changing more so than we're talking about. She came out of it this time.
The oxygen you put on her helped out.
It seemed like that's when she finally started coming around. But eventually she's going to do that again.
Yeah.
And there's a possibility that oxygen is not going to change that, because I typically don't see it change that. But with that, the biggest thing to know is y'all's mom is changing and declining.
Mm-hmm.
And I think probably most likely Anna sees it as much as anyone because she's here more.
Yeah.
And I think we envision in our head of what a person's like of the last time we saw them, maybe even comparatively to what they are now sometimes. So for family members that are away, they might not be seeing that as much.
Right. And when I was in there, David was in there, and he had made the comment, I haven't seen her recently. Her food, she wasn't touching food. He talked about how hard it was trying to get her to eat or swallow or take a sip. And so I talked to him about, sort of the disease progression and where we are, that, her body's not wanting that. But, he saw that not seeing her every day. When you do see her, you're going to, see different things that you're not, aware of or seeing that progression that she's going through.
So to recap what you said was, the nurses here told us is that if mom's too sleepy to eat, sometimes it's more dangerous for her than feeding her, than not eating, because she's forgetting how to swallow, and she could easily aspirate, which means getting something into your lungs instead of into your stomach, which can cause pneumonia. So it's more risky sometimes to feed her than to not feed her.
Mm-hmm. And if she is sleepy for one meal and she's awake for the next meal, it doesn't mean she's not going to get to eat the next meal. It's looked at on an individual basis for that time. And if she ate good at breakfast and she's sleeping through lunch and she's not waking up enough to eat, it's more dangerous for her to eat lunch or to be fed lunch when she's not going to swallow it effectively than skipping lunch.
And the background of this, with Alzheimer's, the progression of the disease is we're going to see more sleeping. We're going to see less eating, less drinking, less socializing. And those are all normal things. And they're hard to see those things because we're used to mom being up and
Doing everything.
Doing stuff and eating is a big part of our life in terms of social. When we get together, we usually eat something, or eating makes you feel better, and that's what we do when we're sick. But at this point in the stage of the game, like Sherry said, forcing food on her could be counterproductive. It could be a lot worse.
And if she does not eat a meal, and if she doesn't eat breakfast and she wakes up at 10:30, you can always go back to the kitchen and ask for a health shake, a supplement, or you can even ask for, I can't think of the name of it, it's a little cup, a magic cup, thank you, and give her that. Sometimes smaller quantities when she is awake and capable of swallowing is better than trying to get a whole meal down.
Right. I also noticed I bought her some baby spoons yesterday, like littler spoons, and I took one in there for David just a few minutes ago, and he wasn't able. She eats from that a lot better because it's smaller and it's not forcing her mouth so much, and it's soft.
I just let her know because we have some in the kitchen.
Okay. The fact of someone else feeding her, she doesn't want to open her mouth really wide. But not very long ago, I could put her food on the spoon and she would take it to her mouth. There'd be a big bite on there, and she'd open her mouth just as wide as she needed to. When she was feeding. Yeah.
And also, sometimes people will let you put food in their mouth, but there's times we find that people pocket the food in their cheeks, and if she's not swallowing it and holding it in her mouth, then later on when she's trying to breathe, she will actually get that down the wrong pipe as well. So
now it's just puree. So
but it does actually. I've seen patients that will look like chipmunks almost after you're feeding them. You're like, what's going on? And then you look in their mouth, and all the food you've given them is
in their
pocketed in their teeth.
And it's not like they're trying to be obstinate or disagreeable. Their brain is not working.
They just don't remember what to do with it.
It doesn't remember what to do with the food once it's in there. So it's not her being, obstinate or anything. It's a brain process, and it directs everything. So, in this process, we see that, again, she's going to be sleeping more, she's going to be eating less, drinking less, socializing less, withdrawing, and just kind of going that way. And that's the body's way of trying to settle things down and close things down in preparation for her final journey. So, we may see periods of a day where she doesn't eat. You may see a couple days in a row, but you can always offer bites and sips, and she'll be kind of like a toddler, the toddler will eat when the toddler's tummy is hungry.
Right,
And the toddler won't eat when the tummy is not hungry.
right.
And at some point, the tummy isn't going to be hungry anymore, and they'll tell the brain, don't eat, don't swallow, and this is what we'll see eventually. Doesn't mean she will die from dehydration or starvation. That's
Right.
not how this is going to work. It's the body's way. That is the body's way of shutting down there. So we're going to have those hills and valleys, like Sherry spoke about. We're going to have good days and bad days. We may have good days in a row, and then she may be tired, really. So it's just kind of a one day at a time, sometimes 1 hour at a time progression.
Oh, we might have a great month,
We might have a great month.
and we might have a not great month.
One fear that I have is that if she gets her days and nights mixed up, and there's not many people, that go and see her at night, she's alone and scared, don't know where she's at, awake at night, and sleeping during the day, and I don't know, that's something that can be worked on.
Well, I think we can work on that, but I think lately she's been sleeping more, period.
All the way around. Did she sleep last night?
Yeah, but she was moaning during the night. But my thinking was, let her sleep when she can.
Right, yeah.
But I don't think it's as much about her days and nights being backwards as that
Just
she
sleeping
is,
a lot more.
She's just going to be sleeping probably during the night, maybe waking up, but also during the day.
Right.
And that's just going to be her.
her new norm.
And did I give you the booklet when the time comes? Did I give you a booklet last time?
I read a booklet, one of y'all gave me. I think I was telling you about that. Was that what the one I was?
Okay, I have some more that I can give.
Okay.
You have such a large family.
Yeah.
I think it'd be very beneficial for people to read it. It just tells the signs and symptoms which are normal
Yeah, that's the one.
at the end of life, and it kind of gives, in one page, there's a quick, fast look at
Right.
3 months out, 1 month out, 1 week out, hours, days, and how they can all intermingle as well. But I can tell you, definitely, we're seeing social withdrawal, eating less, sleeping more.
Right.
She may have
breathing. She did have that apnea the other
Right.
day.
And she may have periods where she's more social.
Yeah.
Like yesterday, I told
She was
her,
singing
"Are you
the other day,
sleepy?"
yeah.
You heard her.
And I told her, "Are you sleepy?" She sang yesterday too, and I said, "Are you sleepy?" And she said, "Yeah." Take a nap. She's like, she pretended she was sleeping. She's like,
Oh, cute.
Yeah.
and laughed with me. So
So even take 1 hour at a time.
but then, yeah, like 2 hours later, she was
you just have
really
to,
in pain
embrace
and-
those when you're here, when you're there. And
when people come in and see that, they shouldn't think that, oh, she's all better now, because
it's
Right.
It's
That's
hour
what I
by
do. I
hour.
think, she's going back up,
But also, there's often times when people have rallies before they actually have
Right.
a decline. And that's them giving you the time that they think you need before they start separating again. So that's even at times, even though this really great moment you have, which is great to have,
to embrace that.
could be that the next day things are completely different. But that was a good moment for you and her. So, I think we always want to have hope that, this is going to go away and we're going to have much better time, when sometimes we have a roller coaster ride as how things are. And that's okay.
And Sophia posted something really cool. What dementia or Alzheimer's does is that what you write this morning about it, just how scary it is. People, you don't know people, and
yeah, do not expect her to know you. Don't ask her a ton of questions.
just hold her hand.
Hold her
and
hand.
talk
Her
to
sense
her.
of touch is what she
Sense of
has.
touch, yeah, that's what it was.
Her sense of touch
You can
and
read to her,
yeah,
sing to her.
Right.
sing to her.
And she seems to really respond.
She responds really well to music.
Yeah.
Now, there's something else that I want to talk about, because we talk about how it is for her. It's also something I think this week I got a good taste from somebody explaining to me as a spouse to a person with Alzheimer's that was really declining, of how it was for them. And this was a gentleman who's been through a lot in his lifetime. He actually went to World War II. He's done a lot of things. He's had a really hard time. He saw the concentration camps in Germany.
Wow.
He has lived a lot. And he said to me, I have done a lot of things, and nothing is harder than watching this process of my life. And so in that, I think we have to be mindful of everyone here and everyone that's going to hear this also knows that this really affects him in a terribly bad way. If he can compare it to what he saw in the concentration camps in Germany, it being worse, this is hard. So it's not only how it affects her and what we can do to make her life better, but how we can deal with the stressors of how this makes us feel.
Right.
Because this is one of the hardest things that y'all have ever done in y'all's whole life. And that's hard.
Yeah.
And dealing with the fact that it's hard. And accepting it is hard.
Were you going to say something about singing?
Sylvia's always tried to be so strong for all of us. Yeah.
Yeah, you were talking about music earlier, and I've read many studies, and I've seen firsthand people with Alzheimer's dementia who are not able to utter a word, have any type of conversation. You can sing a hymn with them, and all of a sudden they can sing word for word. I have many people I visit with that the only conversation they have is singing hymns. That's a gift from God. That's something that is created within us. Scripture tells us that God put the hymn of praise within us to sing him, and that ability, when you hear, they might not be fully aware of what they're singing or even that they're singing along with other people. That's why I always encourage, if they have music in the background, play that music. I just came from a visit from here where a person that's close to being homeless state, and I told them I was going to sing some hymns to them, and they asked why. And I said, as long as they're alive, their spirit will receive that. Their heart will receive that. I always encourage families. Music ministry is very powerful and therapeutic to the soul, to the body. Help her relax. You can see someone that looks agitated, that looks restless, that's not able to express that because of the disease process. You start playing music for them that's familiar to them, and you'll see that peaceful calm just starting to take over. So that's something
that is absolutely true. I've seen that through her so many times. Last night even, she was crying and trying to say something, and she gets started trying and she can't articulate, and it frustrates her, I think. So she starts blubbering.
Yeah.
And so as soon as I start singing to her and pet her head, she just immediately calms down. It doesn't really matter what I sing.
Right.
She just loves the music so much that if you sing to her, she just immediately calms down and just gives her a peace. It's very true. I've seen that.
And I don't know if y'all have she's in her roommate right now. If y'all have a radio that has a CD that y'all like, that y'all could put in there and have them turn it on every so often. They'll do that, for if you have a specific time, like after she lays down from lunch, would y'all go ahead and turn this on, and then it'll be on where it'll play. That's something that y'all can do. And
I had bought her a little radio and was keeping a Christian station on for her. But then I realized that I can set the alarm, and it was afraid to wake her up in the night, so I took it home to my husband to fix it.
Yeah. But, if you unset the alarm and you were playing music and you thought the channel was good, or if you just had a CD you wanted to play a couple hours a day, that's something that they can do that would be calming for her.
She's such a social butterfly. She's always been such a social person. And I've noticed, when Laquita was here yesterday, our oldest sister, she was singing to Mama live, and Mama just calmed down. But when I played it back for her later, and I was singing as a human in the room singing, it didn't have as much effect on her. She just kept crying. She just hears it. You have to be the human, and you're touching her while you're doing it. So I think it's a combination. But I think, because I was thinking that too, but maybe it still will work. It's something I noticed yesterday, that she's just very in touch with the humans around her.
Right.
But
I think that you're playing things with her.
I know.
As well, so they've even
Kelsey was in here last night doing that.
A lot.
It was really,
And I don't see very many places that do that for the residents.
One of the ladies who works last night, she plays the guitar, and she was here last night.
Donna sings a lot to
And
residents. She goes from room to room.
She's a blessing.
She is.
Yeah.
She helps out in activities.
And she plays a ukulele.
She works.
She is. She has a beautiful voice.
She really does, yes.
Yeah, I was gonna ask her that in a second, yeah. We have my oldest niece, Jamie, on the phone, my sister Sheila, who's just older than me, my brother Randy, and my oldest brother Rule on the phone. So I'm gonna go in order of how people arrived. So Jamie, did you have any questions or comments or anything you wanted to share?
I know, I'm good.
Sheila, did you have
What's
anything?
that?
No, I said Sheila. Do you have anything, Sheila? Do you want to come off mute? Do you have anything?
I'm listening. No, I think what you guys are covering it pretty good. Just the idea of when I'm there that I won't feed her if she's not hungry and let her sleep, and so y'all are covering it really well. I appreciate it.
I mean, and it's okay to like touch her and wake her up and talk to her for a little bit. I mean, when you come to visit Sheila too. I mean.
Yeah, if she's not eating, but if you can't get her awake after you've tried to feed her, then probably just let her sleep.
Yeah.
But if you try to wake her
Right.
up and eat, then that's fine.
Yeah.
Good point, Sheila. Rule, did you have anything? I think you came on next.
Were you going to ask Randy?
Yeah, but you were on first. I was going in order of.
I thought she's going by right. Whenever she's talking to you and she can't communicate, if you just say, yes, I know, Mom, she gets it, and so she calms down. If you don't, she'll start crying because she can't communicate to you.
That's a good point. To kind of just go with what she's saying. Even if you don't understand.
Yeah.
To go with it, and if let's say she's talking to someone who isn't there, just don't say they're not there. Just say, oh, so Uncle Sam's in the room or whoever.
And
okay.
don't keep asking her what.
Yeah.
Don't keep trying to make her clarify. Just say,
okay.
Yeah, I agree with that. That's a good point, Mom.
Cool.
That's good.
Yeah.
Rule.
And the more you do that, the more she can communicate. Because what she needs to do is, I have the same thing. I have to slow down when I communicate. If I get in a hurry, I can't communicate at all because I had a stroke 2 years ago.
Oh, okay.
And if I go fast, or if I'm interrupted, then I can't think of what I'm going to say. So she has it more severe than I do. So she starts trying to talk, and you just say yes, yeah, wow, and eventually she can get it, and she starts talking to you.
Okay.
And it's real nice, yeah. And the other thing is the time that we're all talking about here, Mom hadn't eaten all day. She missed breakfast, she missed lunch, and she missed dinner except for a little bit of kefir. And so when they go all day without food, there's a real problem.
However, that's going to be what we expect at this point. That's actually normal. She's going to have some good days where she eats maybe 1 meal, 2 meals, 3 meals, and then there are days that she may not eat anything but a sip of kefir. But however, the staff and family can continue to offer food, and when she will take it, when she's awake enough to eat, as long as it's still being offered, which is, definitely
What you want.
affirmative.
Yeah.
Right. The piece about it is worse to offer someone who is so lethargic food because she is at risk for choking and becoming food stuck in her pipe, and that could create pneumonia. is at risk for aspiration anyway, but this kind of creates a double risk.
And she's not getting any exercise, so she's not going to require us food like we will anyway.
That's true. She's pretty much chair-bound, bed-bound, and
Right.
her requirements are less than what an active person is. That's true.
Well, I want to interject something if I can. I was here for her dinner time that evening, and that was when we chose at that point not to get her up because of her lethargic state. And
Who's that talking?
this is the nurse from Valor Hospice. But when she was giving, she got medicine in some crushed up medicine. She typically could take some of them whole, and she couldn't then, in pudding and the small drink. Shortly after that, she actually coughed quite a bit. So just with a small amount of pudding with medicine in that, she was very, very close to aspirating then. I can tell you, in my professional opinion, that if she would have had her pureed diet put in her mouth and been there that evening, that she would have aspiration pneumonia at this point. So there are times when the risk of feeding is worse for the patient than not feeding them that meal. And I don't know about breakfast and lunch because I wasn't here for breakfast and lunch, but I was here for dinner. And that's when we opted to not, before they had gotten her up, they did not get her up, actually per my request, because she was so risky to choke, because she could not keep her eyes open, and she could not stay awake that evening.
And she couldn't swallow.
And
Right.
she couldn't swallow. And she couldn't, we actually tried to, I had your sister try to give her a drink through a straw in the first place, because if a person can suck up a straw, then they are able to swallow more effectively than if they cannot suck. And she, at first, couldn't suck at all. And then when she was really, really stimulated by your sister, she sucked on the straw and got it almost to the top of the straw and could not get it the rest of the way of the straw and let it go. And at that point, I said, until she wakes up more, she doesn't even need a drink, because she does not effectively suck it through a small straw, she was not awake enough to take drinks of something at that point. So that's some exercises that I have that actually show whether a person is awake enough to be able to function, to eat, and she was not able to wake up enough to do so at that time.
And so later, I got some sponges from the nurse and sponged her mouth. And that actually got her waking up, and I was able to feed her a little bit of applesauce.
So she ate some
A couple of bites of applesauce. And then she said, no more. I'm tired. So I said, okay. And when she said no more, and she woke up enough, it surprised me, she just said no more.
And sometimes we have to listen to what a person tells us physically and even verbally. And sometimes people can't verbalize to tell us, but they're showing us signs of what they want. And we have to be mindful and watch for those signs.
So Randy, did you have anything?
Well done. Well done.
Yeah, I'll go back.
Okay.
Randy's part, but no, I think everything's been explained quite well. Thank you.
Well, did you have anything else?
Yeah, she hadn't taken her 2 pain medications for I can't remember what the dates were.
The reason I brought that up on the message was because some people thought she had pain medicine was making her sleepy. Her pain medicine is just PRN, and I was explaining to people she hadn't needed it for a couple of days, so that wasn't what was causing her to be sleepy. But she don't have to have it every day, just when she needs it. And she hadn't been needing it.
Sometimes we look for why a person is sleepy. Well, are they sleepy because we did this or that? Or are they sleepy because they stayed awake all night? Are they sleepy because they've had narcotics? Are they sleepy because they've had more anti-anxiety medicine? There was nothing different in her patterns of medicine or anything else that made any sense of why she was like she was the other day.
She's not on pain medicine. She's on it as needed.
Right. And it's Ultram, which is non-narcotic.
Yeah.
But sometimes people do say that it makes them sleepy. Just like somebody tells me sometimes Motrin makes them sleepy. It depends on the person. But she hadn't had any of that lately, so that was not the culprit.
Right.
Because we will look at that. Because
She
sometimes
wasn't
people,
missing her medication.
Right,
No,
she wasn't
she was-
missing any medication, no.
I think we need to look at that as a nurse perspective. If a person's very sleepy and not eating, we need to make sure we haven't over-medicated them with some medicine that's made them that way, but that was not the case for her. So we had to look at what we've done different, and there wasn't anything different. It was she was different that day on her own. And I'm glad she's doing better, and that she woke up and ate really good at breakfast the next day and lunch. I'm glad that today is a good day.
Well, today she ate half her breakfast, and now she
She ate a whole bowl of oatmeal, and I put in some Ensure in it, and I put in some sweet potatoes and apple grabber, one of those kind of baby food. I put some of that in there and mixed it all up.
And a lot of times I will skip. She skips lunch, right?
I mean, for me, if I eat a bowl of oatmeal, I'm full.
Yeah, right. I would be full too. Yeah, for that long, especially not doing anything.
Yeah. So
yeah, her calorie expenditure is not very much.
Right.
So she ate all of that, and then she ate some of the gravy and some of the eggs. A little bit.
That's a lot for
And
her.
then she was like, I'm full.
That's good.
So when I was talking to her Monday night, a couple of times she said she was hurting, and I wasn't sure if she was truly hurting or if she was just trying to get attention. And so I probably should have called for pain medication then.
Yes. And we will assess her if it seems like she's doing that very pattern-like. We could actually request that her Ultran be given routinely in the morning and the evening or something like that. And that's totally reasonable as well. We don't want to give it if she doesn't need it,
Right.
but we could look at if there's a pattern of how often she's needing it. If she needs it every evening or she complains of pain in the evening, we could make it routinely in the evening, one dose, and then have it needed otherwise. And that's something we can watch.
Okay.
And all of us can watch that and let us know what they see as a pattern so that we'll know if we need to do that, we can. Because she can't ask for something on her own. She has to show reasons of why she needs it.
She was doing that last night. She was in pain. She kept crying and telling me she said, I'm hurting. So I went and asked the nurse to give her some pain medication, and they did. And
And when I'm here during the week, if I hear her get anxious or something, I'll get up and I'll go find one of them and tell them, I'll probably need to give her something.
And a lot of times it's her stomach hurting. And sometimes when she says her stomach hurting, it's close to a mealtime. And I'll just say, are you hungry? She says, yes, I'm hungry. And, and I feed her. And like, was it last night we did that?
Yeah.
Yeah, she was hungry. Before, later on she was hurting again.
Later on she was hurting again.
Yeah.
And sometimes I think I put on the message on Facebook is that she's in, like you said, like a toddler. She doesn't know what's hurting.
Wrong.
So asking her what's hurting, it doesn't really, she says, I don't know. Or yesterday she said my head, or she might not know what's hurting her. And it could be something simple as, she's got a headache, or
she's itching from
somewhere.
She had yeast infection.
Yeah.
She'd be itching,
Or she's got, a pain in her foot or something like that. It could be something innocuous, but she usually will tell you. I mean, she will not verbally tell you, but her behaviors will tell you.
And sometimes she could be just anxious. Sometimes she could be sleepy, tired, or, someone she's crying sometimes.
Yeah, that last night when I sang to her, she calmed way down. I kept singing to her and stroking her head. And I was going to mention this on the call for others that are listening, that it seems like touch is so important too. She really likes holding people's hands, and she loves having her head stroked, and she loves touch. That really seems to calm her down. Otherwise, sometimes she starts getting anxious and moving her hands around, and she'll reach a hand out,
for you,
and that might mean she wants to hold your hand. Touch seems really, for her at least, in my observation, very helpful.
She's always worried that she's not doing what she's supposed to be doing all of her life in life. And I always tell her, Mom, you're doing just what you're supposed to be doing. I always try to reassure her.
Well, with 12 kids, you had to be doing something all the
right,
time.
I know.
Oh, my goodness.
I know.
Whether it be laundry or trying to cook them a meal or whatever.
Probably really hard for her to sit still if
Yeah,
She says, yeah, what am I
And
supposed to be doing?
Yeah, and I always tell her, I said, Mom, it's fine for you to rest. You know, you've done enough already.
I even tell her, I said, you just worked hard all day,
Yeah.
so it's time for you to rest. And then last night she asked me, am I ugly? I was like, no, you're beautiful.
Yeah.
Aw.
She's like, oh, good.
I'll just come and tell her she's beautiful. And
Yeah.
she goes, thank you.
Yeah, just saying how, definitely when older people can't talk that much, giving them compliments. Oh, you have such pretty eyes, or, you're beautiful. Just kind of pepping them up that way is good stuff. I'm glad y'all.
Yeah, we do that. I told her blue eyes this morning when I was feeding her. I said, I want to see those pretty blue eyes. She looked at me and she's like, okay. So, anybody else have any questions? I'm recording this for others to hear later that can't be here, so hopefully the recording will come out okay.
I guess if she has pain and it's just gas, you still would call for a pain med?
Well, last night we thought she had gas, Sheila. The question is if she just has gas, should we still call for a pain med? We tried Mylanta first earlier in the night, and that still didn't seem to stop it. And she didn't seem like she was really passing gas, but she was still hurting. So after a while, I went ahead and asked them to give her some pain medicine, just to ensure she wasn't laying there in pain, that I didn't know what it was.
And there are times when I have patients who can't express to me effectively what is wrong, that if I think they're hurting, I would rather give them something for pain, which she's on non-narcotic medicine, than to let them hurt and not know for sure if it is. So if I'm going to err and I think it's 60% for sure, I'm going to err on the side of giving them extra help. Does that mean she might get an occasional Ultram that she might not have had possibly, but does that also mean that there's times that we wouldn't give her something and then we would worry about it? So I would rather err on caution side and make sure she's comfortable than be 50% sure that she's hurting and not use anything. And that's part of the hospice philosophy of comfort. And, when I have a backache and I take a Tylenol, it makes me feel better, I can express that and do that myself, but she cannot. So that's hard sometimes.
She seems to get kind of bloated up and hurting a lot in her stomach area. She went in the hospital for the diverticulitis and bleeding ulcer and UTI. So, part of me wants to still try to figure out what's hurting her. But, really there's no way to find out yet. That she's on, Carafate, Zantac, and then she had some, Mylanta last night? She had that PRN too. But the other two routine.
If she's coughing a lot, what about cough medicine?
She has cough medicine.
She has it on, so that's fine.
And that's as needed as well.
Yeah, okay. Sheila, does that answer your question?
Oh, yes, that's great. Thank you.
Does anybody else have any questions? Comments?
I still like
Jokes?
to figure out if there's anything we can do to find out more what's hurting her tummy so much. Her intestines, I guess.
Well, and I think that's just the second when she's hurting, figuring out if Ultram, if she were hurting in the evening often, that we could actually automatically get that if we feel like it's happened consistently.
Because I have the nurse listen to her a lot and I say, there's good sounds in there.
Yeah. But I think our biggest thing is trying to keep her comfortable. And I think occasionally, well, why is she uncomfortable? But I think keep her comfortable. And there are things, if we start being concerned that her urine is extra strong, or we will do a UA.
Right.
It's not like we're not doing anything to treat her. But, at the hospital, they found that there was issues then. She's not going to go and have an upper GI done because we're looking at that kind of thing, because that's not about comfort as much as curative. And we, as a collective group, had discussed that for her, what's best for her, is not to pursue extreme aggressive treatment.
Right.
I mean, comfort. But we're looking for comfort for her. So that's where you have to, your brain shifts a bit about, we'll treat what's going on, we'll make sure she's okay, we'll try our hardest to figure out what's wrong, and if we see symptoms that are concerning to us, we will do a urinalysis or we'll do whatever we need, but that's not been her issue currently.
Right. I think what your concern was, Anne, we don't want her to get another one of those where she's so bloated that she's bleeding and has blockages. And,
right. And we listen to her every time we come, and the nurses here actually do listen to her as they need to as well. So she's getting assessed.
Right.
Okay.
It doesn't mean it won't happen.
Right.
I mean, it could happen again. I hope it doesn't.
Right.
But she's just prone to that because of her diverticulitis and her issues with her gut.
And another thing is that she expresses to me a lot. She'll say, "Don't leave me when I'm here late at night, I'm about ready to go." And I think she knows that. And the thing I think is important is that she knows when her kids are here, and that she does see her kids a lot, family as much as they can.
The other thing I noticed is that one night when I was at the hospital with her, Ann told her bye, and she was upset the rest of the night about that. And don't tell her bye when you leave. Don't tell her bye. Just tell her
the noise outside, and
just tell her that you love her. So just tell her that you love her. Don't tell her that you're leaving.
All right.
That's what I did when I left. When I went back to Seattle, was I just said, "I love you, Mom. See you in a little bit."
Yeah. Okay.
And then she's like, "Okay."
Okay.
And that way,
so she was upset.
It's a habit because
I know.
You're saying, "Bye, Mom, I love you," but when you say bye, she sees that as
you're leaving.
You're leaving her.
Good point.
That's a good point.
Yeah. That's
So
really
see you instead of bye. See you later.
See you in a little bit. See you later.
A lot of times she'll say, "Where are you going?" I say, "I'm going to my bed and you're in your bed." A lot of times I'll say that. And that's
true.
Okay.
I tell her, "I'm just going to run down the hall.
Yeah.
I'll be back."
But she sometimes thinks that, she's in her house. So I'm going to my bed and you're in your bed, right?
Yeah.
Mm-hmm. But that seems to make her happy.
But I don't tell her goodbye anymore. I just
What's
it's hard. It's caught myself and hard to adjust when I was
Yeah.
leaving the hospital.
Right.
Go back to Seattle. I was like, I don't remember that. And I left, and I didn't do it. And I was like, "I'll be back in a minute." And like, okay.
So we want to be sure that going forward, he doesn't get a UTI real bad and diverticulitis and ulcer and all that. He was pretty bad when she got to the hospital this last time.
And we can't say we're going to prevent that. Any of those things could happen with her disease process. If she had signs of a urinary tract infection, the thing is, her body.
You have to watch for it.
And we do watch for that, as well as the nursing.
Really.
But we can't say that it's not going to happen. I mean, she could have another flare-up of her diverticulitis. She could have those things happen. Her ulcer could flare up just from her stressors of, that she gets anxious sometimes because of the disease. But we can do our best to treat her symptoms and hope that those things don't happen and be proactive. But I can't say any of those three won't happen.
But you guys monitor it.
Yeah.
And now you have the nursing home with additional help in monitoring that and looking for that and knowing that she's at risk for that.
Yeah.
And knowing what state she's in.
And with her dementia at the stage end, she is at increased risk for those things because of the disease process. And I think that's where we got to wrap our mind around it, that we have to get our mind around the fact that this disease actually makes a person more prone to have aspiration pneumonia. This disease makes a person more prone to have a urinary tract infection because they hold their pee instead of peeing sometimes, because they forget. And that's part of the process. And I wish it wasn't.
I noticed last night, too, that she was hurting, and then she peed, and then she wasn't hurting.
Right.
So I think even she was forgetting to pee, and
she just needed to go pee, and it was hurting her.
And it was hurting her, but she didn't. She was forgetting how to, that she needed.
And then she peed.
And then she peed, and she was better.
Mm-hmm. So they put her in the bed. She peed. So we talking about,
So in that, that's normal for her process. which would have made her uncomfortable because when you need to pee, it is uncomfortable, you know, when you dance around and you pee. And then you pee, you feel better.
Right.
But that's very common because of the disease and its advancement.
Yeah.
It seems like the more that Sophie's been here a lot, she just seems like she's even like got better. I don't know, just the people being, you know, family being around her seems to help her a lot.
Yeah. With family being around her
Being
helps
around
a
her
lot.
helps her a lot.
Sure, it definitely helps with her spirits and so,
Yeah.
she's in better mood and
Right.
things like that. So you definitely want to embrace those moments,
Yeah.
and we hope that they keep happening.
Right.
But there will probably be some times when they're not happening as much.
Right. Yeah.
One other observation that I had is that when there's a bunch of people talking in the room, she might get agitated because if there's only one person talking at a time and you talk directly to her and not around her, that she's kind of aware of that.
Yeah.
Even though she's, you know, has dementia, there's certain senses that
Yeah.
things like people have that she has that a bunch of people talking is confusing because she doesn't know which person's talking to her. And so even if you're just talking on the phone or like I've been trying to step outside when I talk on the phone so that if she thinks I'm talking to her and I'm not, I don't ignore her. So
That's a very good point. So sometimes
Yeah.
a lot of stimulation can be very anxiety provoking.
yeah.
So it sounds like, and you guys have a big family, so, you know, maybe taking limits of how many people are there, or if there's a lot of people in the room, just maybe, you know, like you said, one person at a time talking to mom. If you have side conversations, maybe take them outside so she doesn't get confused or worried about them, or telephone calls.
Good point. Yeah.
Anything else? We really appreciate you guys making the time to do this and for everybody being here.
Actually, I do have a little bit of the family. Possibly some might be in denial, or you know how we get help with that. Like some might be in denial, some might be like not accepting it, or you know how can we do better to go through this process? Not for mom's sake, but for our sake.
One of the things I can think of, and I'm sure Kirsten has some good suggestions of books to read about this process, of maybe she could give y'all some titles and maybe people would want to pick those books up to be able to understand it more. Because I think a lot of times we don't want to accept what this is. And I know you know, sounds like I think I know what I'm talking about, which I don't always, but I have experienced this disease from my grandmother, from her start of onset till the time that she died, related to complications of Alzheimer's dementia. And I remember that's actually when I just became a nurse, when she got very sick, and I learned some things that I had not been able to help out with the family with her earlier on, that I have wished that I could have used with her. So all of those things are really about thinking about how we can make this process as easy as possible, even though it's very hard. And those are the things, and I think the biggest piece for me as a nurse is that helping people understand and accept what it is. And I don't want to accept the disease. I hope someday they find a cure and nobody has it. That's what I want. But until they do, we have to deal with the repercussions of the disease.
Sure.
And I hope that she has good months for a long time yet. But part of me with her symptoms that she has this week worry me that we won't have as many good times as we will, if possible, other things coming because of symptoms that she started to show occasionally.
Yeah.
So, and that's me watching as an outsider without the emotional tie to what that means. And so it's easier for me than it is for y'all. And I know what it's like to be on the other side of that, and it wasn't easy at all.
Yeah.
So just know that we have the best intention to try to help y'all through this process as easy as it can be in a very difficult situation.
I can definitely text you, Ann, titles of books and give you some more of those booklets for
Okay,
your
all right.
siblings.
Okay.
That has about 4 or 5, so, you know.
All right.
Yes, one final observation is thinking about what I was saying earlier about being in her room, that's her space, and to be super self-aware of how you're being in her space. If you're agitated, you're going to bring that agitation to her space.
Yeah.
If you're, upset, you might bring that agitation into, I guess, manage your own idiosyncrasies and your own tendencies to interrupt and talk and, whatever. We have a big family, so we're a family of interrupters and talkers, so it's hard to manage that sometimes. But I think just bringing it to the forefront of awareness for the people that are in her space and to be respectful of where she's at and manage themselves as much as possible. I don't always do it either.
But I definitely agree with your point. And,
Okay, all right. Okay, all right. Thank you.
that's a very, very insightful, and I'm so glad you said that because a lot of people, be self-aware is it's not said a lot. And definitely people, especially who can't express themselves or having trouble expressing themselves or even sleeping or in a non-responsive state, they can feel all that energy.
Right.
Now you can choose to bring in good energy, or you can choose to bring in bad energy. I hope you choose to bring the good stuff or the calm stuff, because she's gonna feel that even if she's asleep.
Right. Wow. That's
And
good.
she can hear potentially us talking.
Right.
So if you're talking about her or about something that she's done in the past or about something that's about her to other people in the room.
Absolutely. Hearing is the last sensation to leave. It is present to the last breath. So even if she's sleeping or sometimes, she may be in a non-responsive state. We haven't really seen her be totally non-responsive. But hearing, she will always be able to hear, even if she's hard of hearing.
Right.
So please be aware of your conversations because she can hear everything.
But I want to let y'all know also, we spend as much time as we can in the room with her to listen for the choking and all those things. And when we chart, we bring computers and charts in her room. So if y'all see us on the computer in the room, it's not that we're hanging out playing games. I want y'all to know that too, because I actually spend a lot of my visits documenting her visits in her room, in the other side of the room, actually plugging in and doing her notes and printing them. So there is actually some time that we're in the room present that we aren't talking to her. So I want y'all to know that too, so y'all can know that that could be happening. Yeah. And it should be happening if we chart when we're here.
Yeah,
Right. And if I choose to chart in her room versus down at the area, if I actually choose to chart in her room and I have the time to be able to do that, which I do often spend the time in her room, I will hear her if she's clearing her throat or she's coughing.
Gives you more time to watch it.
Yeah.
And
or if she's
I've been working.
moaning.
Yeah, I've been working in her room as well on my computer. So,
but I want y'all to know that because everybody would see that. Well, why is she on her computer in her room? Is she? I want them to know that we actually are using that for time that is specific because of her.
And that would be, observation is a huge thing, especially when people can't communicate or when they're not able to at that moment.
And with people watching, I don't think they get verbal cues. That sounds like back in the day I had that ringtone.
Hey, Bob, can I call you back in a little bit? Or you call Dad? All right. Okay.
And I will not do that today when we're here because I'll do an assessment on her, a quick physical assessment.
Okay.
This has been a good portion of the visit because this is still important, very important.
Absolutely.
I think this is as important as anything.
Right.
Yeah. I'm glad, Ann, I want to commend you on calling, asking to get together early and just kind of dispelling any myths or having any questions. We've only been going since the 24th, which is about roughly 2 weeks. So I want to commend you for that, and I think that's a great thing that you're on the speakerphone and recording, especially since you have such a large family, just to make sure everybody hears the same thing. So thank you very much on that part.
Okay, and another thing that was brought to my attention from Sandra that's in her office was that all the family, some way or another, let her know, that we're okay with her, with how things are going. I mean, we're okay with it. So how did she express it to me? Mom wants to know that all her kids are getting along and happy and are okay with her going home, basically, to let her go if we need to.
Yeah.
That's an
There will
important,
be a time when that will happen.
that will,
You will know when it's time for you
Right.
to be able to express how you feel. It will,
okay,
those things, everything happens the way it's gonna happen.
right. And that we are all getting along and we love her and we're happy,
Mm-hmm. And all of y'all want what's best for your mom.
Right.
I truly believe that. I can say that confidently that that's everybody's intention.
Mm-hmm.
Right.
Absolutely.
Yeah.
Yeah.
But
Okay.
yes, that is something to keep in mind. I don't want to keep this meeting going forever, but is to be thinking about, Mom at some point will need to hear what you're thinking and that tell her, whether it be on the phone or in person, because if there's a situation you can't get here, whoever's here family-wise can hold up the phone and just let her know that you're going to be okay, that you don't worry about. If I were Ann, don't worry about me, Mom. I'm going to be fine. You go be with Daddy in heaven, and Jesus is waiting for you, or however you want to say it. That way she won't, sometimes people do tend to worry about others here in our present state, especially if there's family stress, and just to let her know that, everybody's getting along. We love each other. We love you, things like that. So that's all I've got.
Okay.
I'll stop recording now. Teresa, looks like you're the last one on. Yeah. So, love you guys, and I hope everybody gets to hear this.
Thank you much to everyone there, the nurses, Ann, Sophie, Daniel, all of you guys. Me and Randy are very grateful for everything you do.
Oh, thank you, Teresa. Look, tell Randy we love him too.
We'll talk to y'all later.
Okay.